Good morning, good afternoon, and good evening, everyone. Welcome to the fourth webinar in our WFPICCS Pediatric Respiratory Critical Care series. This episode is on lung recruitment and prone positioning in pediatric ventilation. My name is Georgie Pazimilis. I'm a senior physiotherapist in the PICU at the Queensland Children's Hospital in Brisbane, Australia. I'm joined by convener Dr. Milan Jambaji, Head of PICU and Emergency and Retrieval Services at Ankura Hospital for Women and Children in India, and co-convener Dr. Farhan Sheikh, lead paediatric intensivist at the Rainbow Children's Hospital in India. My fellow moderators tonight are Dr. Michael Canary, Associate Professor of Pediatrics at Yale School of Medicine and attending physician in the PICU at Yale New Haven Children's Hospital, and Dr. Abdul Rahman Adathan, Pediatric Critical Care Consultant at the Ahmadi Hospital in PICU, Kuwait. As you think of any questions, please post them in the chat. We'll try to get through as many of these as possible at the end of the presentation. This episode and all past sessions are available for free on the WFPICCS YouTube channel. And when you leave the session, you'll be prompted to complete a survey. It takes less than 1 minute to complete, but the feedback is extremely valuable for us to guide future sessions. So please take a moment to fill it in. You can also register now for our next webinar titled Under the Hood, How Modern Ventilators Really Work. This will be taking place on the 20th of May. And finally, a reminder that the WFPICCS World Congress is taking place from the 26th to 30th of September in Melbourne, Australia. Early bird registration is still available until the 30th of June, and the draft program is up on the WFPICCS website for you to peruse. I'll hand over to Dr. Abdul to introduce our speakers.
Thank you, Georgina. So without further ado, I'm honored to introduce to you Professor Brenda Morrow. Professor Brenda Morrow, she's a physiotherapist and full professor in the Department of Pediatrics, University of Cape Town, South Africa. Brenda has a special interest in interdisciplinary pediatric critical care, practice and research, cardiopulmonary rehabilitation, cystic fibrosis, palliative care, and medical ethics. Brenda has over 160 peer-reviewed publications, 21 book chapters, numerous national and international congress presentations, and holds a Southern African National Research Foundation. She is immediate past president of the WFPICCS and current president of the Critical Care Society of Southern Africa. Brenda is an editor-in-chief of the Southern African Journal of Critical Care, Senior Associate Editor for Pediatric Critical Care Medicine, and Associate Academic Editor of Plus One. She is regular reviewer for over 40 international journals and grant funding agencies. Our second speaker is Dr. Peter Rimensberger. He's a professor of pediatrics, intensive care medicine, and neonatology at the medical faculty of the University of Geneva. Was Director of the Service of Neonatology and Pediatric Intensive Care, Department of Pediatrics at the University of Hospital of Geneva until 2022. His special field of interest are respiratory physiology, respiratory failure, and cardiopulmonary interaction, with a well-known expertise in mechanical ventilation in neonate and children. He has published more than 180 peer-reviewed articles and reviews and edited a major textbook on pediatric and neonatal mechanical ventilation. Besides his activity as reviewer for many scientific journals, he was associate editor of Pediatric Research, editor advisory board member of Intensive Care Medicine, and editor board members of Pediatric Critical Care Medicine. Currently, he is a section editor of Intensive Care Medicine, Pediatric, and Neonatal. He was executive committee member of the European Society of Pediatric and the Neonatal Intensive Care, that's the SPINIC, in various positions from 2002 till 2019, and was elected medical president from 2015 to 2017. In 2021, he was awarded the Dennis De Victor Award for recognition of lifelong contribution to PICU and NICU care. So without further ado, Professor Brenda, the mic is all yours.
Thank you so much, and thank you for the invitation to present this webinar. It's very exciting to see so many people in the room, and I welcome you. So I've been tasked with speaking on lung recruitment and prone positioning in pediatric ventilation, and I've tweaked that a little bit to focus on pediatric acute respiratory distress syndrome management, because one of the main learning outcomes of this talk was related to the PALICC guidelines and pediatric ARDS. So just very, very briefly, the pARDS 101 as an introduction, just to remind ourselves that when we're talking about pediatric acute respiratory distress syndrome, we're talking about a heterogeneous clinical syndrome that is associated with very high morbidity and mortality. pARDS is caused by acute lung injury, which may be direct pulmonary causes, for example, as a result of a lower respiratory tract infection or inhaled toxins. Or it may be caused by indirect lung injury, for example, as a consequence of systemic inflammation, as we see in sepsis. And this syndrome is variably characterized by acute widespread inflammation of the lungs, diffuse alveolar damage, and lung capillary endothelial injury with associated severe hypoxemia. Most of you will have seen the PALICC outputs. I think there are 11 outputs from this consensus organization that updated the definition and severity stratification of pARDS, along with recommendations for the diagnosis, monitoring, and management. And I'm not going to go into those in detail today, but you can find those freely on the internet. The PALICC guidelines included a range of clinical contexts for pARDS, possible pARDS, and at risk of pARDS. But for this talk, I'm going to focus on patients with full-blown pediatric ARDS in invasively mechanically ventilated patients, or IMV pARDS. So these 4 boxes represent the 4 main arms of ventilator-induced lung injury, which contribute to the development of pARDS and the exacerbation of pARDS, all of which should be mitigated by lung protective ventilation strategies. So firstly, there's atelectrauma, which refers to the repetitive opening and closing of unstable alveoli and lung units with each breath. This generates shear forces and injures the lung. Barotrauma or pressure injury is quite self-explanatory by applying excessive pressure and causing air leaks. Volutrauma is volume injury. It disproportionately affects regions of the lung that are actually already aerated. When collapsed regions don't open, the tidal volume is also distributed to a smaller lung, sort of the baby lung concept, which causes overdistension of open alveoli. And then we have biotrauma, where mechanical injury triggers cytokine release and exacerbates the injury that's occurring. So these aspects all create the central tension in lung protective ventilation and in recruitment considerations. We want to open collapsed alveoli. We want to keep them open, but we also need to be careful of avoiding overdistending alveoli that are already open. And the physical underpinning for why recruitment maneuvers carry an inherent overdistension risk and why we need to monitor so carefully is my absolutely favorite law of physics, Laplace's law, which states that the pressure that's required to distend a sphere and to keep a sphere open is proportional to the surface tension, but most importantly, it's inversely proportional to the radius. If we apply this to the lungs in pARDS, a collapsed alveolus has a small radius, so it requires a very high pressure to open it. And that is why recruitment maneuvers need elevated pressures above the standard tidal pressures to pop open the de-recruited alveoli. In the green area in the middle, once the alveoli are recruited, the larger alveolus now has a bigger radius. And by Laplace's law, it now requires less pressure to remain open. And that's the benefit of recruitment, but also the potential danger. Because when you apply a high recruiting or distending pressure to alveoli that are open, to open collapsed alveoli, that same pressure is simultaneously applied to both the collapsed and the already open large alveoli. And in those alveoli that are already open, that large radius means that wall tension is escalated and continued pressure increases the risk of barotrauma and lung injury. I also just want to briefly mention the role of surfactant here. So we know that surfactant normally stabilizes the alveoli in the Meade effect by reducing the surface tension as alveolar radius decreases. So that really counteracts the Laplace tendency for small alveoli to empty into larger ones. In PARDS, though, surfactant is actually depleted. And so that stabilizing mechanism is also reduced or lost, which again predisposes alveoli to collapse. And it also emphasizes the need to maintain expansion after recruitment by adequate PEEP. Otherwise, those alveoli that have been expanded are just going to collapse again. Before I dive into recruitment maneuvers themselves, I also just wanted to touch on driving pressure as a very important concept for lung protection and for evaluating the effectiveness of recruitment maneuvers. The driving pressure is defined as the difference between plateau pressure and PEEP. It essentially represents the pressure swing and stress that the lung experiences with every breath. Because driving pressure is also equal to the tidal volume divided by respiratory system compliance, it's also a much better variable to use than tidal volume or peak inspiratory pressure in isolation, because importantly, it accounts for how stiff the lung is. If you have two children on the same set tidal volume per kilogram, they can have completely different driving pressures because their compliance differs. So the child with very severe ARDS and poor compliance will be experiencing vastly more alveolar stress per breath, even though you may be doing the right thing by limiting tidal volume. When we look at how to measure driving pressure correctly should be done using plateau pressure measurement, which requires an end inspiratory pause or occlusion hold. And that really needs a ventilator that supports that function, that can actually support an inspiratory hold. It also needs a patient that's adequately sedated, because spontaneous breathing efforts during the hold can then contaminate the plateau pressure reading and can make the driving pressure unmeasurable. The driving pressure is important. In adults, it's been shown to be the single strongest ventilator variable predictive of survival, stronger even than tidal volume or PEEP alone. The pediatric evidence is still emerging, as with much of our practice, and we don't yet have a clear signal of association between driving pressure and mortality. But increasing driving pressure is consistently associated with morbidity in terms of duration of ventilation and PICU stay. The PALICC recommendations are to limit your driving pressure to below 15 centimeters water, and that's based on the adult studies and physiological plausibility, as well as limited observational pediatrics data, noting that the Ralph study did not use plateau pressure to measure driving pressure. They actually used peak inspiratory pressure in the context of decelerating flow ventilation. We do know that in many settings, particularly in resource-limited settings, plateau pressure is very seldom measured, and it may not be feasible for a number of reasons, including having older ventilators without that occlusion hold function, staffing pressures, different sedation practices, unawareness. There are many different reasons why it's not done. And in different contexts, it may be reasonable to consider using delta P, as in the difference between the peak inspiratory pressure and PEEP, to maintain protective ventilation. But we can't consider PIP minus PEEP to be a surrogate or a replacement for true driving pressure, because it systematically overestimates the driving pressure, considering that it includes both endotracheal tube and airway resistance. But moving on to lung recruitment maneuvers, I think there is an important distinction that we need to remember between a lung recruitment maneuver as an acute maneuver, as opposed to PEEP titration that should be seen as an ongoing strategy, although the two are very closely related. So a recruitment maneuver is really like trying to open a door that has been stuck shut. It's a deliberate transient push beyond normal tidal pressures to pop open collapsed alveoli. But once those alveoli are reopened, as I said earlier, you need to then keep the door open. And you do that by applying adequate PEEP. But once the door is open, the pressure to keep it open is going to be less because of Laplace's law. But if you don't hold that door open with adequate PEEP, the newly opened alveoli are just going to collapse again at end expiration. So a lung recruitment maneuver without subsequent PEEP optimization is probably futile. The two have to go together. And we can see this in this compliance curve. During inflation, the full line, solid line, transpulmonary pressure overcomes the critical opening pressure at the upper inflection point. After recruiting during deflation, the dotted line, the lung volume is going to be greater at the same pressure level, and alveoli will remain opened as long as the PEEP is kept above the lower inflection point, that critical point. And the goal of the recruitment maneuver really is to maximize the number of alveoli that are participating in gaseous exchange. We're also wanting to reduce tidal strain, improve oxygenation, and reduce, that's seen really in reduced driving pressure. There are different ways of recruiting that have been described in the literature, and there is very variable practice across the world. We know this. The first description of recruitment maneuvers was of sustained inflation. And this is probably the simplest maneuver. You literally held the breath, a single breath, at 30 to 40 centimeters water for about 30 to 40 seconds. And that's really what it looked like. The problem, though, is that these sustained maneuvers caused a significant and sustained rise in intrathoracic pressure, which was associated with reduced venous return and cardiac output. And in a hemodynamically vulnerable child, it is potentially dangerous. And these sustained maneuvers also seem to have quite a short-lived effect, but many studies that investigated this did not actually optimize PEEP afterwards. The next type is a stepwise incremental PEEP maneuver, and this is what most experienced units will use and what is generally recommended. So here you gradually step up the PEEP, and I'll get to exactly how just now. We find a point of maximum recruitment, and then you slowly step the PEEP back down to the optimal level. So this is more time consuming, it requires vigilance, but it does give you better hemodynamic tolerance, and it tells you what PEEP you actually need to hold the alveoli open. And then finally, you have the concept of intermittent sighs, which could be the most physiological approach because we all sigh naturally. Here's one, as we are speaking, as we are breathing, which may periodically recruit microatelectasis. In some ventilators, the units actually do have programmable sigh functions, but not all ventilators. And this strategy is not supported by high-level evidence. We really only have preliminary observations from small adult studies to date. In the PICU context, stepwise incremental PEEP is generally preferred for safety reasons, and you'll see the strategy is the most endorsed by PALICC as well. Importantly, I think we need to remember that a lung recruitment maneuver is not a first-line intervention. It's not the way to find PEEP in the first instance. We need to reserve these maneuvers for when your standard and as optimized as possible ventilation settings are not achieving adequate oxygenation. You can also consider them after any de-recruitment events, disconnections, circuits changed, for example. In terms of contraindications, hemodynamic instability is probably the most important contraindication in pediatric practice. If your child is on significant vasopressors or has poor cardiac reserve, the decreased venous return during a recruitment maneuver could precipitate cardiovascular collapse. Undrained pneumothorax is an absolute contraindication, and we need to be wary of the potential for air leak syndromes here. And to mitigate harm, it's very important that we obviously need to monitor throughout. We need to watch our heart rate, our cardiac output, SATs throughout, and have stop criterion in place before you start. If you find your blood pressure is dropping, your SATs don't improve within an expected window, then you should be stopping, you should be reassessing. When we look at what the PALICC guidelines say, unfortunately, PALICC was unable to make a recommendation for or against the use of recruitment maneuvers in children, noting that there were no pediatric-specific randomized control trials. PALICC did consider 3 clinical studies in just about 60 pediatric patients with PARDS that reported the safe use of a staircase incremental recruitment approach with a signal of sustained improvement in oxygenation and reduced PCO2. So based on those observational studies and adult studies, PALICC added an additional comment that careful recruitment maneuvers may be considered to improve oxygenation, and that was based on expert consensus only. But importantly, the guidelines only conditionally endorsed the use of slow incremental and decremental PEP recruitment maneuvers, not sustained inflation maneuvers. As I said before, we also know that there's considerable variability in practice, and the 2025 European PICU survey highlighted just how much variation there is in clinical practice, with centers, and this was across Europe, but across the world it's even more variable. They use different techniques, different pressures, different monitoring approaches, and no standardization. And I think this is really an active and urgent research gap. We need some dedicated pediatric evidence. But at the bedside, if we're looking at how we actually do it, the PEEP titration recruitment maneuver is ideally performed in the pressure-controlled ventilation mode because you can set and control both PIP and PEEP, and then you can also accurately measure and document changes in driving pressure at each step. Some people also do this maneuver in volume-controlled mode, so you increase PEEP with a set tidal volume. If you're doing that, a change in your peak inspiratory pressure can give you a directional signal that recruitment or overdistension is occurring. So your technique will be that you'll start at a baseline PEEP, and then you'll increase your PEEP, typically in steps of about 2 centimeters water at each step, with a few minutes of equilibration at each step. That small step size is suggested by PALICC based on the quite marked adverse events that were noted in adult trials who used large PEEP increments of about 5 centimeters water. So the smaller steps are recommended, and they allow earlier detection of overdistension before you cause lung injury during your recruitment maneuver. At each step moving up the ladder, you will assess oxygenation, hemodynamics, compliance, tidal volume, and ideally you will measure your driving pressure response with a measurement of plateau pressure. When you increase PEEP and the driving pressure goes down, that tells you you are recruiting lung, you're doing good. You are expanding the lung. The tidal volume is now distributed over a larger aerated area. You'll continue incrementing until there's a plateau first, and then there's a sign of overdistension, or obviously if there's hemodynamic compromise. And at that point, you then drop your PEEP stepwise again to your optimal PEEP, where driving pressure is the best, and that's just above your closing pressure. So your monitoring tools, at the minimum, you are wanting your pulse oximeter to measure your oxygenation. You can look at your ventilator displays for compliance trending, measuring driving pressure. And if you are in a fancy unit, you may have an electrical impedance tomography unit where you can actually, in real time, you can monitor your regional ventilation distribution, but that is not widely available. But I think lung ultrasound deserves a special mention here because increasingly it is available in all resource settings. It doesn't have a radiation risk, can be done at the bedside in real time, and you can visualize your B lines resolving, consolidation reaerating as PEEP increases. And I think for units without sophisticated monitoring tools, lung ultrasound is really a practical and powerful tool, and I think we need to be using it more. Okay, now let's switch to prone positioning in pARDS. And this can also be considered a recruitment strategy, and in fact is often used in conjunction with recruitment maneuvers to optimize ventilation. The key concept supporting prone position is that in the supine position on the child's back, the dependent dorsal lung regions bear the weight of the heavy inflamed pARDS lung. In addition to that inflamed pARDS lung, they also have the weight of the heart and the abdominal contents. And as a result, those dorsal areas collapse. The non-dependent ventral regions will stay open, but they then carry the bulk of the tidal volume, and as such, they start becoming overdistended. And that is the inhomogeneous high stress and strain pattern that drives lung injury. When you turn the patient prone onto their stomach, you then flip that distribution. The dorsal regions are now no longer dependent, and because the heart is sitting on the sternum rather than compressing the dorsal lung, you get the additional benefit of reduced cardiac compression. In prone, the shape of the chest changes as the compliant chest wall is restricted. The ventral regions now become more dependent, and they do tend to collapse under the weight of the dorsal regions, but the net result is that more lung is open to ventilation, resulting in more homogeneous ventilation distribution and reduced stress and strain in the prone position. Importantly, though, as Gattinoni himself said, proning is not for everyone. For there to be a positive effect, there would need to be heterogeneous ventilation in the first place. And we've actually demonstrated this in a small study using electrical impedance tomography. We did this in children with moderate to severe PARDS in our ICU, and we showed that some children responded positively with improvement in oxygenation index, whilst in other patients there was no response. And we were able to show that responders actually had a more heterogeneous ventilation distribution at baseline, which became more homogeneous together with the observed improvement in their oxygenation. By comparison, the non-responders had fairly homogeneous baseline ventilation, and they showed no change after proning. I think that the variable response to proning that we observed as well just lends support to an individualized approach and not a one-size-fits-all approach to proning. When we look at the evidence supporting proning, in adults, we have the landmark Perceiver trial by Guerin and others that provided robust data in almost 500 adults. They randomized patients to proning for 16 hours or more a day compared to supine, and the mortality benefit of proning was found to be dramatic. The 28-day mortality of 16% compared to 32%. Unfortunately, in children, we do not yet have evidence of a survival benefit. Yet. We all know the Martha Curley trial from 2005, which is the largest publishable pediatric RCT to date, including just over 100 children from a number of centers in the United States that were randomized to proning for 20 hours a day for 7 days compared to supine. And whilst 90% of patients randomized to proning did show improved oxygenation, the study was stopped early on the basis of futility. There were no differences between the supine and the prone groups in the number of ventilator-free days, mortality, time to recovery, or functional health. But with the trial being stopped early, we do have less robust evidence, even of a lack of effect, because sufficient power was not reached. What we do consistently see across observational studies and other smaller trials is an oxygenation improvement, which is clinically important, because improved oxygenation is real, and it possibly can buy us time and clinical breathing space, even if a mortality benefit is unproven. Looking at PALICC and what the guidelines say, unfortunately, the recommendation was that there was not enough definitive data to either support or refute the use of prone positioning in patients with PARDS. There's acknowledgement, though, that in practice, prone positioning is used, and it's mainly used as a rescue or an adjunctive therapy in children who are not responding to optimized conventional ventilation. And so PALICC provided expert consensus supporting that approach, even in the absence of a formal recommendation. In other words, you could consider proning in patients with PARDS and hypoxemia who do not respond to other interventions. But if that is done, then the improvement in oxygenation needs to be assessed. Subsequent to PALICC, there have been 2 systematic reviews with meta-analyses, ostensibly focused on the pediatric population. I'm presenting these, but with some reticence, and you'll see why. The first systematic review from 2024 was by Chin and others. So they did include pediatric studies, and they showed a clear oxygenation benefit of proning, with no effect on mechanical ventilation. And here's where things get interesting, because this group then presented this meta-analysis, which does show a mortality benefit. But they used a fixed effect model, and I think we can be a little bit critical here. Considering this, there was substantial clinical heterogeneity between the included studies, and there was actually meaningful between study variance. For the statisticians around, there's a tau squared of almost 0.5. So you could firstly argue whether you should even pull these studies at all. And then if you look at the small sample size with only 4 studies and few events, and an I-squared statistic of almost 40%, I think at the very least a random effects model should be used. And in fact, when I played and reran that analysis with the same studies, using a random effects model myself, you see that although the signal is still there of a possible mortality benefit, the confidence interval now is very wide, crossing the line of no effect. In other words, the mortality benefit did not survive the more appropriate analysis. The other recent systematic review that initially made me excited was also published in Frontiers this year, ostensibly including only pediatric trials and again reporting a clear mortality benefit, using initially what I thought was an appropriate random effects model. However, on closer inspection, and thanks to my moderator, Peter Rimensberger, for pointing it out, the review analysis actually inappropriately included a number of studies that were done solely in adults. Most notably, the Perceiver trial by Gurin is included in this analysis. It contributed the largest sample size, the largest number of events, but it was not a pediatric trial. And in fact, some non-randomized studies were also included, which deviated from the stated methods of the study. And in fact, when I looked into it even further, at least 8 of the 13 included studies in this entire systematic review should have been ineligible according to the stated inclusion criteria. So, I am looking at this a little bit further. I just think this is a warning to all of you not to take the published literature at face value. This is quite concerning. Really, what we're waiting for is Prospect. It's a trial that we're all waiting for. We've been waiting for it for a while. Comparing prone versus supine, it also compares high frequency versus conventional mechanical ventilation in severe PARDS. So the study has closed to enrollment. We are all eagerly awaiting the results. And when we see them, I'm hoping that they will be able to reshape and inform how we approach prone positioning in pediatric practice. So please watch this space. So the physiology and evidence are important, but so is doing this safely. As for most of our practice, though, most of the protocols and checklists for proning have come from the adult world, largely during COVID, actually. But I've tried to apply these to children, and I've also used Prospect's protocol to inform suggested but not evidence-based method of proning. So this is adapted from Prospect. So Prospect required 5 to 6 team members to turn a patient. Just to mention that this is just not possible in resource-limited settings. In our setting, there may be only 2 or at best 3 people turning an infant, sometimes only 1, but there should be 2 people. At the very least, you want 1 person to be only managing the airway, but that person could also be leading the turn. And then you have somebody else who's managing the patient's body and attachment. The most critical role is the airway guardian, the person at the head of the bed who's controlling the endotracheal tube throughout the turn and does not leave that position, because endotracheal tube displacement is the most dangerous complication of proning. It's completely preventable by just making sure that you strap your tube properly to start with, and then that you have a dedicated, competent person whose job it is to secure the airway. In terms of a pre-proning checklist, you're wanting to check for contraindications or precautions. Pre-oxygenation certainly helps prevent the very common transient desaturation that occurs. Making sure that all of your lines and your airways are well secured and verify their position. There's a debate about whether we should be holding enteral feeds or not. I think it makes sense to hold enteral feeds, but you can carry on with post-pyloric feeding, but that is debatable. Something very simple but important is make sure that all of your lines and catheters are long enough that when the patient turns, they don't get stuck. Make sure that your eye care and your pressure checks are done, and then you can place your pressure care supports in place before you turning. The actual turn really just requires the team leader to call and coordinate. It's not rocket science. Ideally, this could be practiced using simulation training, where really you have a leader calling the move, you move the patient. Importantly, position the head to the side, check that there are no tubes and lines that are going to cause pressure injury in the new position. Make sure that your supports and pressure pads are in place over bony protuberances. And after the turn, make sure that you check your ET2 position. Has the child still got bilateral breath sounds? Check all your lines, reassess your ventilator parameters, and then make sure that you practice good pressure care thereafter. So complications really are predictable and they're preventable, I think, with a good protocol. Pressure injuries are the most common, so make sure that you are regularly assessing your pressure areas, reposition the face and the head regularly with prone positioning. We know that facial edema is very, very common. It's expected. It's not a reason to turn the patient back into supine, but it is a reason to check your eye care and check your pressure care. The monitoring at a minimum, you're again going to be looking at pulse oximetry, heart rate, blood pressure, end-tidal CO2, for example. Your ventilator graphics are very useful, but remember that when you turn the patient prone, you are limiting chest wall compliance. So you do need to take that into consideration. We're looking at improvements in lung compliance, not chest wall compliance. Driving pressure is underused again as a monitoring metric. It's very useful for children who are prone, especially because they usually are sedated, and so you can get a good plateau pressure measurement. And again, lung ultrasound, I think, is a practice game changer, especially for resource-limited settings. A 10-zone aeration scoring protocol is only going to take about 5 minutes at the bedside, and it does give you real-time feedback on the success of your maneuver. EIT is available, but it remains a research and specialist clinical tool in most settings, so it's not readily available. In terms of how long you stay in prone, again, practice is very variable, but commonly it's between 12 and 20 hours per day, per session. And Perceiver is about looking at 16 odd hours a day. And obviously, you're going to be returning to supine if there are any major adverse events, if you need to access the chest, and also if there is sustained improvement and the patient no longer needs to be in prone. Prone positioning, I think, is particularly applicable in low resource settings because it's one of the few critical care interventions that requires essentially no additional equipment. You need people, a plan, a checklist, and training, and that's all. But the challenges are still real. If you have low nurse to patient ratios, it does make assembling a safe proning team harder. Limited monitoring means you're more reliant on your clinical assessments and potentially ultrasound. But these are solvable problems with the right training and protocols. I'm nearing the end, but I just want to present some of the new work that is being done. This is some of the work that we and others are doing and have been done, looking at the response to proning in terms of improved homogeneity of ventilation really has made us ask some more questions that have sparked, I think, quite exciting new directions in research. So although we've shown an increase in dorsal ventilation after proning, the biggest effect that related to oxygenation seems to be improved homogeneity of ventilation through the lung. And that has led us to ask whether it's actually the gravitational change of turning into prone that causes all the observed positive effects, or whether it could at least partly be more the change in chest shape or the restriction of anterior chest wall movement that occurs when lying prone. Now, identifying an alternative to proning could be useful, especially in resource-limited settings where the safe turn can be compromised by limited staffing, and where you want continued access to the chest for nursing and emergency care. So the question we've been trying to investigate is whether we could obtain similar effects by limiting anterior chest or abdominal wall movement in the supine position. And interestingly, this idea has been proposed by others, largely anecdotally, and I did enjoy this post I found on Twitter some time ago from a colleague from India, suggesting that the reduction of chest wall compliance would improve gaseous exchange. And I'm very pleased to be able to share some of our own group's work here. This is a study led by Eleonora Lozano-Ray, who's one of our PhD candidates at UCT. And really the conceptual question was, if the benefit of prone positioning comes partly from restricting anterior chest wall movement and redistributing stress and strain, can we mimic that effect in the supine position by loading the anterior chest wall with a weighted blanket without having to do the turn? Because this was a novel intervention, our ethics committee required us first to investigate feasibility and tolerability in a less severely ill cohort. So we started off with an exploratory pilot study in non-ventilated children admitted to hospital with lung infections. And the primary outcome was tolerability and feasibility, with the secondary outcomes being oxygenation and change in ventilation homogeneity using EIT. And we actually found that the application of the weighted blanket, so it was easy, it was feasible, it was very well tolerated across all age groups. Most babies fell asleep. There were no significant adverse events. We saw objective significant improvements in comfort. We also saw significant improvements in oxygenation and reduced respiratory rate after application of the weighted blanket. The work of breathing really declined significantly. We did not see a significant change in ventilation homogeneity using EIT, but we didn't really expect to see that with relatively mild disease, and the study was not powered to detect small changes in regional ventilation either. We've since completed an initial further small pilot step in children with non-invasive ventilation PARDS. And these results, again, are starting to make me a little excited. Again, we saw significant improvements in oxygen saturation, in respiratory rate, in heart rate, and comfort scores. And these findings raise the possibility, still a possibility, of a low-cost, low-risk, easy-to-implement intervention that could be useful in settings where staffing for a safe prone turn is just not available. Now, obviously, these are very preliminary findings, but we are looking for someone to take these studies further into clinical PARDS trials. So if anyone is interested, please contact me. I'm very excited to take this further. So in summary and some take-home messages, I think we can say that the physiological rationale is strong for both prone turning and recruitment maneuvers, which is why experienced clinicians carry on using these interventions despite limited evidence in terms of randomized controlled trials and fairly ambivalent PALICC-2 recommendations, it must be said. I think PALICC-2 is honest about the evidence gap, and we shouldn't overstate the guideline support. So based on current evidence, PALICC recommend, and I think it's appropriate, that we can consider using both these interventions as rescue tools in selected patients, but they should not be considered as routine for all children with PARDS. Oxygenation benefit is real and it's consistent in children. And although there may be an emerging signal of survival benefit, even without this, I think improving oxygenation is useful. It can buy us time. It reduces rescue therapy escalation, and it could prevent secondary injury. Safety is everything. I think a poorly executed prone turn or a recruitment maneuver without careful monitoring is probably worse than no intervention at all. So be mindful of safety. Both proning and recruitment maneuvers are feasible in resource-limited settings, but adaptation may be necessary. And finally, pediatric trials, especially in resource-limited settings, are urgently needed to properly inform our practice moving forward. And we hope that by the time PALICC-3 emerges, we have strong evidence to make very clear recommendations for these practices moving forward. Thank you for your attention.
Thank you, Professor Brenda. It was a wonderful talk and very nicely summarized and highlighted about all the points which we actually had expected. So now I would like to invite Dr. Peter to summarize the session, and if you could add a few points from your end, Dr. Peter, it would be great.
Okay, it's a pleasure. Welcome to everybody. So, great talk, Brenda. Great overview, putting together recruitment. And as you mentioned, well-prone is also recruiting. So what are the rationales, just to summarize? The rationale for lung recruitment mean we face the classical restrictive or mixed lung disease in pediatric ICUs. And these pathologies show heterogeneous lung aeration, so it's the heterogeneity. And this is not only true in pediatric ARDS, this is also the case in other pathologies. And just to open up, if there's some neurologists listening to us, it's also this case in respiratory distress syndrome in the infant, as well in neonatal ARDS, meconium aspiration, and others. So I think it's an important part. You mentioned then well that we have the coexistence of collapse and overdistension. And collapse means the risk of athallic trauma, which is probably nowadays a little bit in the risk balance against volute trauma overestimated. The worst one, or the one that really causes the big lesions, is volute trauma and barotrauma. The first proof and hint for this was given many years ago when we got the first CT scans from patients, neonatal patients with BPD, bronchopulmonary dysplasia, because they had the cystic alterations in the ventral parts, those who were overdistended, and not in those who were collapsed. So how can we now minimize this risk between collapse and overdistension? This is all about, we talk for so many years now, started with tidal volume limitation, small tidal volume ventilation, went then up to minimize the inspiratory pressure, and nowadays actually explain the distending pressures. And on the other hand, we had to learn that we need to open the lung So the areas that can be opened. And this comes to the point of recruitability or not recruitable. And I think it's not so clear-cut as a patient is recruitable or non-recruitable. There are many stages in between, which means in clinical practice, we have to test every patient. But with this optimizing, trying to open the lung the most we can, we try to do nothing else than reaching out or bringing back the lung volumes to FRC, functional reserve capacity. And I think this is important to remember. It is also important to remember when you think about hemodynamic interactions, as FRC is the place of the lowest pulmonary vascular resistance. So when you want to have less hemodynamic compromise, it's not merely the question, high pressures may be dangerous. The question is, can I bring back the lung to normal perfusion conditions, which means, which is clearly on FRC. And this is the challenge we have to face. Small tidal ventilation, pressure limitation, distending pressure limitation brings us to the words used sometimes, stress and strain. And first is the stress, you read this in the literature, is the force that you apply to a lung unit. So it's the absolute pressure is a force that you apply to a tissue. And the strain is the tidal volume, actually given by the tidal volume, but not by the absolute number, because it's the elongation from a previous state. You add the tidal volume, you distend these areas, you change the length. And this length depends, or the effect of this depends from where you start on. And where you start from is from PEEP. This means a tidal volume, even if it's small, and you use very low PEEPs in collapsed lungs, can be very stressful, can cause a high strain, high lesions. Whereas if you have an open lung, a larger tidal volume may cause less strain because the FRC is normal. So it's tidal volume divided by FRC gives you the strain index. And this is important to remember. Therefore, focusing just on what we try to do for so many years, just on one simple size of a tidal volume is very problematic. And using now the distending pressure is certainly helping us much better to understand what condition, in which condition a patient is. So because it gives you, as mentioned, a reflection of the lung compliance, or better the respiratory system compliance. It's just the lung, it's only your chest wall involved in it. Then we come to the recruitments, how to perform them. And this is often a question. You mentioned the different methods. And I think at the end, it's as the recommendations are, the stepwise is the only, stepwise up and down is the only one we can recommend. Because with the sustained inflation, also there's still common practice. It's very dangerous because you do not know how high you have to go. Is it up to 25, 30, 35, 40? Some patients need much more because they're less recruitable, they show recruitability, and others may need much less, and the variation is big. And also the timing is just given by the sample like this, 30, 40 seconds. And I mean, even the adult trial showed completely different results when they used in their collectives different timing and different pressure settings. So it can be dangerous because you may create a severe overdistension, may go too high up, or you even do not reach recruitability, so the opening pressures. Therefore, slow step up and down. And the question that is often also raised is, how long do I have to wait? I know it's cumbersome. You can't have a coffee break in your ICU. You have to stay at bedside and wait for the response. So when we go up with 2 centimeters, you wait for the response until the point where you see no change anymore. And it is not because oxygenation improved, you should go on and on. And this is another error that is done. Oxygenation improving, people get enthusiastic and risk then what we call the hidden phase of recruitment is overdistension, which is the one that is the more risky one than having a partially collapsed lung. How to monitor? Monitor, you mentioned oxygen response. It's a direct response. I think during recruitment maneuver, an SF ratio or PF ratio is very helpful. You don't need to integrate the oxygen index at this time because it's much more confusing. You expect it's reducing, the saturation improving, and you can slowly start to turn down your FiO2. So it's a good surrogate marker. The compliance response. In volume control, the delta pressure, the descending pressure. In pressure control, the change in tidal volumes. And then what is also often forgotten is the CO2 response, because the CO response, as soon as you reach over distension, you create intrapulmonary dead space, and your CO2 will go up despite a better minute ventilation you may see on your ventilator. And this is really an early sign indicating that you might do high up. The next ones are the lung ultrasound, electroimpedance tomography. Lung ultrasound is helpful for recruitment opening, but it does not allow you to detect overdistension. So be very careful in using lung ultrasound. If you see opening with BLADs disappearing and things like this, you see better aeration is a good sign, but be careful. It does not tell you when I start to overdistend, whereas electroimpedance tomography, you can work this out. So just keep these limitations you have in mind with these methods and not just believe if I see opening, everything is fine. Then when we come to prone, you showed, and is known, it improves dorsal ventilation in spontaneous breathing as in ventilated patients. I just wonder, as usual, my question, how many of the audience are sleeping on the belly and not on the back? I bet there are more that sleep on the belly than on the back, because that's our natural position when sleeping of all mammalians, in fact. So imagine an elephant sleeping on the back, he could not survive, because he cannot actually breathe it because of his heavy weight of the thorax at the actual points you mentioned in a supine position that worsen ventilation distribution. Prone is at the end, as I saw, is at the end nothing else than recruitment, because it improves homogeneity, better ventilation distribution, which is nothing else that we search for also with recruitment. And I think that's sometimes even a first step, and could tell you, but only sometimes over time, if a patient shows recruitability, if oxygenation is improving. However, the problem is with oxygenation improving that when we see improvement of oxygenation, we believe everything is fine, and then the study shows no better outcome. All these studies, the prone position studies show, as you mentioned, improving oxygenation, but no improving mortality or shorter duration mechanical ventilation. And I think one risk of these methods is the underestimation of overdistension. When proning a patient, you may see the improvement in oxygenation, you're happy, but maybe you forgot that you should reduce your pressure settings on the ventilator because you made overdistend some areas now, the well-aerated one, and you don't realize it by looking just at oxygenation. And that's, for my opinion, one of the reasons that we still do not have convincing data, outcome data on proning, because we're just taking half things in part. Oxygenation is improving, they should be better, outcomes should be better, but that's not the case, because probably just miss the other half of the story. And that the focus, and certainly with the method of electroimpedance tomography nowadays, we should focus much more on this part of overdistension during these maneuvers. So then you have this excellent idea of the chest wall movement, limb restricting. So I'm excited. I don't know how much you put on. I would not be the first one to get me a heavy weight on the thorax, but it makes sense to some extent. So we'll see what is coming out there, but also there probably if you can do EIT, that would be great. I think you do it, as I know you, because this will tell you much more what we need to know. So at the end, I think it's going back, all was also the adults described very well in good reviews is about stress and strain for the lung. And what we also forget is the transpulmonary part. So our distending pressure we have from the ventilator, but what is the patient's condition? What is his chest wall compliance? What is his abdominal compliance or distension? What does this mean exactly? And we do not have any idea about this because we're missing good measure tools. And there's another lack we have in pediatric field that we need to improve our measurement tool to get a step further. So I think the summary for me and one take-home message, be careful, better oxygenation does not mean better outcome. So don't get fooled. Be careful and rule out and make sure you can detect occurring overdistension during such maneuvers, because that's the worst part, the one that creates the most injury. And therefore, stepwise, slow approach, take time is really essential. And also, when you find your best optimal pressure after recruitment in a patient, 6 hours, 10 hours next day, there will be no more be the correct one, and you may, in meantime, overdistend the patient drastically. And this has been shown in several observations. So this happens. And this especially also worked to neonatologists. It happens there even faster in RDS patients. Thank you.
Thank you so much, Professor Peter. That was amazing. Thank you so much, Professor Brenda. You guys are legend and amazing. So without further ado, I'll start with the first question and then hand over to my colleagues, Dr. Milan, Michael, and Farhan. Just out of a question, hand it to Professor Peter. If you have a child who's having severe ARDS, what would be your first choice? Is it shifting him to prone position, or would you go for high frequency? And that was mentioned by someone in the chat. In someone severe ARDS is failing saturation, would you shift him to prone position or conventional, or go for high frequency?
Well, I think it's a little bit difficult to respond to the question as is. What does severe ARDS means? We have the OI definition, the OSI definition, but the question is, is my major problem oxygenation at very high pressures? That should be because it's severe ARDS, or is it also a ventilation issue? And if it's mainly the oxygenation, not so much the ventilation issue, so I'm not stuck with my delta pressure and have high CO2s, then I will probably start first with, depending on the etiology a little bit, but imagine that it should be probably partially recruitable, either with a recruitment maneuver step by step or proning. Whereas if I have really on the limits with my pressures already, I will switch to high frequency oscillation, but also during high frequency oscillation, recruitment or proning have to be done. This is not exclusive. It's just changing the mode, allowing you to handle better ventilation.
Thank you, Dr. Peter. So I would like to ask the next question to Professor Brenda. How do we know that a lung is recruitable? Because as we have seen, the main reason why the ART trial had shown higher mortality and higher incidence of air leak and lower ventilator free days, mainly because they did not assess for the recruitability of the lungs initially, including in the intervention arm. So at bedside, how do I know that these lungs are recruitable?
So maybe Peter can also weigh in here. So from an electrical impedance tomography perspective, you can actually measure it. You can look at the shape of the curve of an inflation-deflation curve, and you can get an idea of whether there is recruitability. I think we can look at that whether that heterogeneity exists. So do you have a mismatch? And by doing the recruitment maneuver, you can see what the response is. I think that's probably the most important one. So if you start doing a recruitment maneuver and you're seeing your driving pressure is dropping, your oxygenation is improving, your compliance is improving, you are recruiting the lung. If there's no response, you're not recruiting. So that would be my answer, is looking at response. But Peter, is there another way that you would approach that?
No, you look at the response again, keep all the parameters in mind, and just do not just look at oxygenation. But if you don't see a response in oxygenation, you don't see a change in compliance, and you don't see anything happening with one step, with 2 centimeters more, I would go one step further. Whereas when you see that what we do, your compliance is worsening, or your CO2 comes already up, and this would need continuous CO2 monitoring, and I always advocate for transcutaneous CO2 monitoring, as you do not have online blood gases for CO2, then you know this lung, or the lung is at higher risk to overdistend before it might recruit or not. And this would be a point of return.
Thank you. So, Dr. Farhan?
This question that Lucien et al. Demonstrated bedside assessment of lung recruitability using a P from 15 centimeters of water to 5 centimeters of water. However, in children, we normally don't use positive end expiratory pressure as 15 centimeters. So in pediatric age group, is it okay if we calculate the RI ratio by dropping the PEEP from PEEP of 10 centimeters of water to 5 centimeters of water instead of 15 to 5? That's the question.
So, I need a little bit of help with your question, because you talk about reducing PEEP.
Yeah.
I mean, what I'm a little bit confused is that reducing from a certain number to a certain number.
So the question, I
these
think,
numbers
was...
are individual from patient to patient.
Yeah.
So we cannot say I should go from 8 to 12. And you remember perhaps PALICC guidelines had some numbers of PEEP. You should not go, but you can consider go higher, because nobody wanted to give a word and accept that recruitment might be a slow approach to understand what's going on in the lung. In PALICC 2, we finally managed to get this out. So arguing with fixed PEEP numbers is very dangerous. I would start in any patient you intubate for severe respiratory failure with a PEEP of 5. I start first to get ventilation right, so that I can handle CO2. I turn up the FiO2 as high as possible if needed to keep saturation in an acceptable range. And once we are there, we start to think, is it recruitable? And then it's a very small step approach. And once you see that you start to open up, or you start to overextend, you come immediately down. Usually coming down you can do faster, but then you have to find the point of collapse where actually saturation drops. And not stay because you had to open up, for example, you had a PEEP of 12, let's say, and your intra-inspiratory pressure was 28. And then you come down and now say, well, PEEP of 8 is okay. It might be still over this patient. You have to find the lowest PEEP pressure, so it might be 6 for this patient, not 8, but it might be again 5. So it's really exploring, and when you see that the patient starts to recollapse, then you have to go up and come down again. That's the only way to find the PEEP pressure that this patient needs at this very moment. Also keeping in mind, then when you use larger tidal volumes, you need lower PEEP pressures than you need when you use smaller tidal volumes. So it's all these things are going together. I don't know if this responds a little bit to your question.
Yeah. No, basically the question is about Lucien et al.'s paper, which was published in 2020, in that paper, what they did was they dropped the P from 15 to 5, and then they measured the compliance at 5, and they calculated the volume of recruitment. And
that was the other
the
paper.
question, yeah. So now the question is
recruitment to inflation ratio.
Yeah, RI ratio. Yeah,
Yeah.
recruitment inflation ratio. The question is, in pediatrics, we can't use PEEP of 15. So is it okay if we drop the PEEP from 10 to 5 instead of 15 to 5? That's the question.
What is the need to measure recruitability by this? It's really, the problem is what is forgotten in this concept there is that they also changed the inspiratory pressure. So it's not just a PEEP question. So I do not see any reason to quantify in a way or the other that may be even erroneous if it recruit in a number. So I mean, you can do everything if you want to do this, but then you should do this in a specific study looking at this. But I would not do these big steps because so hemodynamics will suffer, the patient will not be, I would not do it. Just simply, I know this paper from Brocharsby group at this time,
Yeah. Brenda, you want to say something?
I agree. I was just going to say the same thing. The idea of dropping the PEEP to measure something doesn't make sense to me. I think that we should do the incremental steps and then the decremental and identify the PEEP that individual patient needs, rather than applying an arbitrary very high or very low PEEP. That doesn't make sense to me. I think individualizing and actually finding optimal PEEP for that patient is necessary. And in terms of the PALICC recommendations for looking for setting your PEEP, titrating your PEEP, we're also looking at the ARDS net FO2 table, and I think that can be a good guide as well.
Good guide and a starting point.
And a starting point, and then you can titrate
the low
from
PEEP
there.
FIO ratio schedule.
Next question you will ask, Milind?
Yeah. So this is a very basic question actually. What is and a very common question which usually all the new comers or the beginners in intensive care would have in their mind. What is the time interval among the PEEP increment and the assessment variables? Means whenever you do incremental or decremental PEEP titration, how long do we keep it at that particular PEEP and assess the variables?
Brenda, you want?
So I don't think we've got very strong evidence. That's the problem. So I glossed over that a little bit. Sort of 2 to 3 minutes, but you're wanting, as Peter said, you want to wait for the response. So you don't want to move too quickly because then you can overdistend without seeing the response. So you want to give that time for equilibration. The word doesn't come easily at each step. So it is a few minutes, but you want to give enough time at each step so that you can assess response appropriately. Otherwise, you'll miss it. You'll go up too high, too fast. Peter, do you agree with that?
Yeah. It depends also from pathology, from the underlying disease. I mean, the extreme, the fastest you can go is the neonate with respiratory distress syndrome. So surfactant deficiency, law of Laplace, and that's it. Whereas in a patient with some consolidations in some areas, some collapse and edema in other areas in these heterogeneous lungs, these lung units will not open at the same rate and at the same pressures. So therefore, it's really a slow go. Wait until you see no change anymore before you do the next step. And when you look, for example, at the prone studies show sometimes over 1 or 2 hours still improving oxygenation. So just to show you, it may go very, very slow. This prone, it's slower than with the PEEP step trials. But you may end up sometimes 5-10 minutes waiting in a patient. You still a slow increase in saturation. As long as something moves on your monitoring parameters, I would not turn any knob further.
Okay. So thank you both. So Dr. Farhan.
Yeah, the next question is, how frequently do you need to repeat a recruitment maneuver in a day? So suppose you did it in the morning, do you do again in the evening, or you do once in a day?
Well, this depends what you did in meantime and what you did to the patient in the meantime. I mean, as you had, for example, suctioning for some reason, then you may see a drop in saturation, means a drop in volume, and you need to do a recruitment at this moment now. And as Brenda did studies and others, we know well that also close suctioning is not preventing totally from collapse or from loss in lung volumes. So we have just to be aware that sometimes it might be several times a day, sometimes it's once and it's stable. But if it's once in a acute disease, then you have to ask the question, if the patient stays stable for 12 or 24 hours, you have to ask the question, are my pressures not too high now? And should I try to go down? So it's dynamic, and just keep in mind, every lung disease is dynamic. Nothing is static. So if it's not a severe fibrotic ARDS on ECMO where you need to wait for some days, but the others, it's dynamic disease and this may change. So depending what happens to the patient, what vital signs he shows, what did you do with your FR2 over the last 2 hours, for example, to keep the same saturation, gives you the small hints when you should perhaps do another attempt.
Thank you. So this brings to another question, because there had been a question asking, how will you know before proning about the lung pathology, whether it's homogeneous or heterogeneous? Do we always need a CT, or we can comment it clinically or on an ultrasound or chest X-ray?
So, I mean, I think you often again don't know. Realistically, I don't know. I wouldn't CT every child before turning prone, and I think there are issues with that. I don't think that's appropriate. Lung ultrasound can give a clue, but it's not going to give a definitive answer. Something simple like auscultation, and it's not validated at all. You've got solid dorsal regions on auscultation. Personal experience, that sometimes is an indication, but I think you don't know again until you try it, unfortunately, if you don't have something like electrical impedance tomography. So I think EIT is useful because you can pick up if there is that heterogeneous, that inhomogeneity of ventilation to start with, which is an indication that it may be recruitable. But as Peter said, you may have other indications that you have a recruitable lung. If you looked at you may have done another recruitment maneuver and you've seen what the response is. Is the child responding with recruitment quickly or not? Sometimes I think it's a matter of turning them and then seeing what the response is over a few hours. And if they're not responding, 3 hours later, there's no reason to keep them in that position. I wouldn't say.
Right.
Does that make sense?
Yeah. So, Dr. Peter, you want to add anything?
Just wanted to add, just remember the acute respiratory failure patients, they have hardly ever a homogeneous lung disease. This is the fibrotic patients for some other pathologies, but the ones we talk about, these are all heterogeneous lung disease, and lung ultrasound can help. However, if you do all the fields correctly for assessing, not just a single shot lung ultrasound.
Great, thank you.
The next question is, when we apply recruitment maneuver, I think Dr. Peter has already covered this, but there is a question here. When we apply a recruitment maneuver, there will be an improvement in saturation, compliance and driving pressure, but the improvement in oxygen saturation may be just because there is an increase in the right ventricular afterload and less blood is entering into the lung and contributing to the shunt, and also because of the Henry's law, where you are basically increasing the mean airway pressure, and that's why the partial pressure of the mixture of each gas is also increasing spuriously. There may not be actual alveolar recruitment. So clinically, how do you differentiate between an alveolar recruitment or just a spurious improvement in the saturation?
We're looking at the other parameters, the change mainly in compliance. So if it's small changes, but when you recruit, you increase the functional lung volume. This means this is directly correlated to lung compliance. So you see a small change in compliance. The problem is to see it sometimes because we just look at the numbers very fast, but you have to calculate it carefully. And if you're not sure, go one step further and see if you see something happening now. More complicated is it the same thing under high frequency oscillation, but also there you can see a small change in the delivered tidal volume, as if you can measure it. And the problem is there with the pediatric oscillators, which is still mainly the sensor metrics. We do not have any clue what we do. We just have a pressure and a knob. And that's a little bit of a problem. But with the newer neonatal ventilators reaching out to 10, 20 kilogram babies in the pediatric field, we get much better information now.
And also, I think carbon dioxide exchange also will be a helpful tool.
Sure, but again, who has transcutaneous CO2 and is monitoring this correctly? Don't buy ventilators, buy CO2 monitors.
Yeah.
To improve.
Yeah. So that brings us to another question. Does your approach to proning or recruitment differ between modes of ventilation, like conventional ventilation, or if the child is on oscillator or APRV?
No.
Can prone anyone?
No. Okay. To both. But RPRV, I mean, RPV, however, is a different concept. You have a high pressure and you release very fast.
Yeah.
And I mean, it's sometimes said it's a recruitment concept. But you know all the difficulties we have with APRV, and certainly have no data in pediatrics.
Okay. Great.
And the question is, if a lung is not recruitable, does that mean there is no point in trying prone position ventilation?
No. For me, I would, if you cannot recruit by step-by-step increase, I would not give up and try. I mean, you cannot lose really something. If you don't see a response after hours, then you probably turn back and say, okay, the risk of pressure sources and handling is not in the balance against keeping it prone. But no.
Okay. So about feeding,
even if the lung is not recruitable as such, you can still try. Yeah.
Yes.
Yeah.
Okay. So the question is about feeding. Do you need to hold the enteral feeding when the child is prone, or if you are proning, how can we resume the enteral feeding? How and when?
So again, this is debatable. And I think it's just people's individual practice. We don't have good evidence for it. I would suggest holding enteral feeds during the turn, but not the entire time the child is in prone. That's not what was intended there. But post-pyloric feeding can certainly carry on. You can. I mean, I'm not sure what other people's practice is. It would be interesting to find out. But I know a lot of people tend to just stop the feeds when anything changes, really, and it may be over cautious and not necessary, but it's not for a long time. It really, I think it's just during the turn that the enteral feeds would be stopped. Peter, what's your practice with regards to feeding?
I can't comment. I'm not practicing anymore. No, I think
we continue feeding. We continue feeding in our unit. Yeah, only of course, during supine to prone, when we do at that time, the child will be NPO for some time, but after that we start.
So that's exactly what I'm saying. So while you're doing the turn, you stop it, but then you turn it on again. You don't keep a child unfed for the entire time they're on their stomach. That would be poor practice.
So basically, it's not a contraindication for enteral feeding, proning. So we can feed.
Yeah, certainly.
Dr. Farhan.
Yeah.
Now There is one question. Is there a single reliable test to know which patient will benefit from proning?
No, it's by turning and seeing the response in the same way that you recruit and you see what the response is. I don't, Peter, you agree with that?
I agree. In general, you cannot lose when you prone a patient. Then you see a response, may you see a response only after hours. Remember again, 2 to 3 hours in the most studies, and they see still improvement, or some of them still only improvement then. Therefore, it's also a reason to keep them longer proned, for example. And also with a recruit maneuver. I mean, if you go careful, you do not sustain inflation, things like this. You just go careful. You cannot lose. You just have to be watch carefully. And it's not just recruitable, not recruitable. It's everything in between is there.
And you may have recruitable lung units and you have non-recruitable lung units. It's not like you have it's not one system.
It's heterogeneous.
Exactly, it's heterogeneous. So there may be areas that are recruitable, even if there's a trend to non-recruitability. There may be areas that are recruitable within that can still make a difference.
Okay. So, question, if we are a resource-limited country where we don't have continuous invasive blood pressure monitoring, do you still recommend proning in such children in ARDS? And if so, are there any hindrances which we should be careful about?
I still think one should prone, and you monitor what you are able to monitor, and you clinical monitoring. As I said, in low resource settings, it's one of the interventions that requires virtually nothing, and it has potential benefit. So I would still prone. I would still try prone ventilation.
So, Dr. Peter, you have anything to add?
I would certainly also try prone, and would just remind you, don't forget when you get a good response to turn down your pressures after proning, because that's the thing. Everybody's happy, good saturation, and nobody moves. And this is probably what then we are missing the main issue.
I think that may be why we aren't seeing responses in older trials as well.
That's what that's
because it was people were just turning, but they weren't chasing after the turn. And I think that you have to combine them, otherwise you're not moving forward at all.
Right.
Thank you.
Next question is, how much pressure you place on the anterior chest wall? Does that amount of pressure depend upon the age and weight of the patient?
So in the study that we were doing, yes, absolutely. So we standardized the weighted blankets according to patient age and size. So the size was measured quite carefully, and the weight, I think it was 10% body weight. I think I'll have to just check, but I think it was 10%. So it was calculated very carefully. The chest wall could still move a little bit, but it was just restricted in the extent of movement. And it was, it's very comfortable. And we used similar to the X-ray screening, the lead weighted, so we actually very carefully measured and manufactured the blankets to restrict the chest wall movement. But please, I'm not recommending this in your practice. I'm just highlighting something interesting for the future.
Very interesting.
Very interesting.
I think it may be interesting moving forward. And I thought maybe it's just something interesting to share with you.
Yeah.
Okay. So one last question from me. So can you share if you have any experience of using mechanical power and driving pressures in recruitment maneuvers bedside?
It's yours, Peter.
Yeah, driving pressure, it's very easy to have it bedside. And I mean, again, just keep in mind, driving pressure is nice, but you're in a pressure control. You won't see the driving pressure as an indicator of reducing driving pressure to recruitment. But if you manipulate your driving pressure during recruitment because compliance improved, and tidal volumes went up, then you have this as a good surrogate marker. And I think during recruitment, I would search to work with the driving pressure with not more than 12. And by the way, adult data shows now the magic number is probably closer to 12 than 15. Okay. In the pediatric field, we do not have really big numbers. We only have these 2 observational studies that showed when they looked them retrospectively, outcome was better in those who never saw a driving pressure above 15. So that's the only pediatric confirming data we have at the moment. There is some first oncoming neonatal data on this, and there they seem to have a cutoff, but it's just early preliminary around 10. But in any case, if you use a delta pressure to start with during recruitment of 12, then you have more a margin on the higher end. And also during recruitment, if you do not observe signs of overdistension, you may go above the limited inspiratory pressure or peak pressure. One thing more to mention is that during recruitment, when compliance changes, time constant changes, which means your instrument expiry time will change too. So because your compliance is improving, the time constant goes up. This means that the time needed to deliver at a certain pressure, the volume is going to be longer. And the error that is done if you are on relatively fast rates, or you do not respect the zero flow condition at end inspiration and expiration and looking at the decelerating flow pattern or pressure control, then you may be fooled by your delta pressure that you read, but the pressure outside will be higher than the effective one on the alveolar level. And that's very important to remember. So you need to know what driving pressure tells you, and you make sure that you have a real compliance situation, as Brenda mentioned, would need to do it with end and inspiratory hold. But this is practically not feasible during recruitment. So if you assure the zero flow condition, then you're very close, and there's data show that this is acceptable as a surrogate for the static compliance when you do a hold. So this is important to remember. With power, mechanical power, I have no experience. I'm not aware of any data at the moment about this. But again, mechanical power, if you want to do it correctly, you would need to have the transpulmonary pressure measures, that you really get the real power. The rest is a surrogate and may be misleading because you may have wrong readings in terms of tidal volumes or delta pressure because you do not respect the time elements from the respiratory system.
Thank you.
Thank you so much. I think other questions are mostly covered in the rest of the answers.
Okay. So thank you, Dr. Brenda and Dr. Peter. I would request Dr. Michael to take over and do the closing.
Sure. Thank you, Melinda. And thank you, Dr. Brendan and Peter. That was rich and relevant and just fascinating to listen to. So thank you very much. And I want to thank all the attendees for joining us. We greatly appreciate your feedback. So kindly fill out the survey and help us continue to do this better. There's a reminder that this and past webinars are available on our YouTube station. A reminder regarding the early bird registration for the World Congress, which ends June 30th. So the Congress is September 26th through the 30th in Melbourne. And finally, I want to invite you all back on May 20th for our next session, where we're going to look at some nuts and bolts of ventilators in a session entitled Under the Hood, How Mechanical Ventilators, Modern Mechanical Ventilators Really Work. So I expect that'll be another great session, and I want to thank my team here for pulling off this, and we'll see you next time, huh?
Thank you so much.
Thank you, everyone. Thank you, Brenda. Thank you, Dr.
Thank you so
Peter.
much. Thank you so much. Thank you so much.